Thank you so much for joining today. We really appreciate you being here. You could be absolutely anywhere, and you decided to join us for the first day of the HS Awareness Week Virtual Summit. Before I get started, I want to thank our sponsors. We want to thank UCB. We want to thank Hydraware, 100-Page Journals, Designs by Muriel, and Burt's Bees. Thank you so much. Oh, and My Magic Healer. Can't forget My Magic Healer. Thank you so much for believing in this summit, and thank you for investing your resources to make this happen. We would not be here without you. So thank you so much. And I also want to thank you all once again. I know I keep saying thank you, but we also would not be here if it was not for you, because this information is for the community. So thank you so much for taking your time to be here. Without further ado, I would like to introduce Dr. Barry Resnik. Thank you so much for joining us today. We are so excited to have you.
Thank you. I'm Barry Resnik, and I'm a dermatologist and cutaneous surgeon in Miami, Florida. And I have been specializing in HS since about 2012. I do the whole gamut of dermatology, but HS is near and dear to my heart. And the sooner I can put myself out of business, the better it will be for all of us. So here is my talk. All you can eat in 30 minutes. We really need to understand what HS is and where it comes from and what it is and what it isn't. HS is a disease that's usually seen sometimes in combination with three other things. It's called the acne tetrad. So you've got HS, you have something called dissecting cellulitis of the scalp, and that is basically HS in the scalp. A really bad form of acne called acne conglobata. Conglobate means to coalesce or to come together. And you have a pilonidal cyst or a sinus. HS is a disease of the skin. You have follicles where the hairs live and they get plugged or occluded, and the plugs can't get dislodged, and the inflammation that comes behind that plug has no place to go but explodes through the follicle and into the skin. And it's that explosion and healing that leads you with what you classically see, which is those scarred plaques. I call them ant farms, and they leak and they ooze and they smell and they burn and they sting and they make your life a living hell. It's a chronic inflammatory disease. I will tell you what it isn't. It is not a disease of infection. Taking a culture, giving you 2 weeks of doxycycline and saying you're done is wrong. It just doesn't work. It's not contagious. It's not sexually transmitted. It's not based in the glands. It's not autoimmune. We may find that there are other things that we learn about this in the coming years, but right now, it is not from not washing well or poor hygiene. It is in the fat and the muscle. It's not in the skin. So when you put all that stuff together, you have a disease that is rarely recognized, although we are getting better at that. And the more we push from the foundation, the more we push from groups like yours, the better educated we will all be. And here is the sad truth. And you probably all have followed this path. You've had this come up. You've seen a couple of doctors, maybe a nurse practitioner, maybe you've gone to your pediatrician, or maybe you've gone to your gynecologist or an internist, and they've told you, hey, you've got cysts, you're dirty, you don't wash well enough, you need to change your diet. Medically frustrated because you've gone to physicians. Physician means to heal. And we haven't done that for you. So you're frustrated, you're embarrassed, it hurts all the time. You're isolated because you isolate yourself and you feel isolated from other people. Bottom line is that the diagnosis of HS shouldn't be that hard to do. You've got scattered bumps, scattered red bumps, scattered ingrown hairs. You've got some bigger ones, and they happen in the same sites, 2 or more areas all the time over the last 6 months. That's the definition. It's an easy thing to do if you're thinking about it. And you all know where these happen. It's usually in the underarms. It's between the breasts, under the breasts, in the inguinal folds, the suprapubic, the buttocks, onto the thighs. It's also in the scalp. It can be around the belly button. It can be on the face within a beard or along the back of the neck. Here's a Hurley stage 1. You see only a few tiny lesions. And when you take the history, these have come and gone a number of times, sometimes associated with the period, sometimes not. Here's another Hurley stage 1. A couple of areas here, a few leftover colors. And part of the problem that patients run into is when they are flaring, that's not the time when they're going to be able to get into the doctor. So you'll call the doctor, you say, hey, I need an appointment like today. Well, we can't see you today. We'll see you in 2 weeks. And by the time you get there, things have settled down again. And then you feel like you've got to convince the doctor, the physician, that you are bad and this is hurting you and you need help. And it shouldn't be that way either. There are some lookalikes. An abscess is simply defined as a walled-off collection of infection within the skin. And abscesses are seen in HS. But it's hard to have an isolated abscess and then see some other stuff and miss that diagnosis. You can have an epidermal cyst, an EIC, and it can be inflamed. And for me, when an epidermal cyst gets infected, when it gets soft, when it starts to fill up with stuff, the name changes to an abscess. Folliculitis as a diagnosis is not HS, nor is acne. But you've got to be able to see the pattern. You've got to listen to the patient. And I grant you, doctors are not listening to patients these days. My whole push for my practice is to catch them as early, catch you as early as we can. Anyone who shows up with any of the things we've talked about, we ask them the questions about HS. Does this happen on a regular basis? Do you have it in other areas of your body? We're now screening every new acne patient because think about it. You go to the doctor for acne treatment, we look at the face and maybe we'll ask about the chest or back, but we won't ask about the underarms or the belly button or the groin. So we've got a set of questions that is part of our EMR. And this is what an EMR, an electronic medical record system, is good for, to consistently ask the same questions, and then you can search and catch those people and keep them from a life of misery. My philosophy of therapy is that this is a chronic inflammatory disease and I need to use anti-inflammatories. Quality of life versus step therapy is constantly being beaten about the head and shoulders. I want the best treatment for the patient that gives them the most change for as long as possible with the least amount of side effects. I don't want to start with the safest, easiest thing because I know it's not going to work. I treat people the way I want to be treated. And who's to say what's severe? You might have 3 lesions and have tremendous pain while someone else has got a lot more and they're not so much in pain. You're the arbiter. You tell me how severe this is. I treat it as it's as severe as possible. Because I tell patients, hey, if I line you up against 99 other people, depending upon their disease, I'll say, all right, you're bottom 10%, you're in the middle, or you're really bad. I said, but if I line you up against you without HS, you're the worst you've ever been. That's how I think about things and how I want to treat you. Pain, underreported, underrecognized, undertreated. So NSAIDs, non-steroidal anti-inflammatories, those are ibuprofen and naproxen and Cilindac and Clinaril, all the other things you might encounter in the over-the-counter lane at your local CVS or Walgreens. I'm a big proponent of medical marijuana and CBD, and I want the combinations. In Florida, it's legal. So I have a friend who went to college with me who's a physician who does medical marijuana. I don't have to convince him that HS hurts like hell. And he gets them on the medical marijuana card and he counsels them on how to use it. There's also something called Realm of Caring. It's out in Colorado. They came up with Charlotte's Web. I don't know if you followed this. There was a very young girl, an infant, who had constant seizures. Her name was Charlotte. And they found that the CBD produced by Realm of Caring stopped the seizures. It was an amazing time. It was a watershed moment for people. CBD, cannabidiol, is the anti-inflammatory part of cannabis. THC, tetrahydrocannabinol, is the hallucinatory part, and a combination of the two is useful depending upon the various ratios. I use narcotics when they're needed. I'm not afraid. I'm not going to get you hooked on something when you need it, because when you need it, you're going to use it. When you don't need it, you're not. A narcotic will get us from point A to point B. It's not something that I'm going to put you on. And if I can't find a medicine that gives you the control that we need, then we're not looking hard enough. I use a lot of steroids, and people are scared about steroids, cortisone, prednisone, methylprednisolone. You shouldn't be. I find that intramuscular steroids really work well for a lot of people, and every patient I see, I want to jumpstart them. I want to give them that turbocharge, and I want to make them feel good for a couple of days to show that it can happen. Because by the time you get to me, you're in a downward spiral, you're depressed, you're anxious, no one loves you, it hurts like hell, it's leaking and burning and stinging and all the things we've already talked about. I want to make you feel as good as I can, as quickly as I can, because you can feel better. And let's say I see you virtually, because I do a lot of virtual visits for people all over the world. I'll use oral steroids. I'll use prednisone, because I need to get you past a flare. And if I can't give you an injection over the internet, this is the next best thing. Neurontin and Lyrica are medicines that block neuropathic pain. These two medicines are originally intended for petit mal seizures. They don't work really well for those diseases, but they work really well for the pain in HS. And Neurontin in particular has a very high amount of medicine that we can use on a regular basis. And it also helps with sleep, because when you're in chronic pain, you can't sleep real well. My mantra: control the disease, control the pain. So common sense stuff. Dairy is bad for patients with HS. And there's going to be a patient every time who says, oh no, I eat dairy and I don't get worse. But I'll tell you, generally speaking, there are a lot of people who flare when they eat dairy. And when we're talking about diet, if you say to me, hey, every time I have arroz con pollo, rice and chicken, Cuban style, I break out, I'll tell you, don't eat it, because you got to use some common sense as well. Nicotine in any form. I used to ask patients, do you smoke? And they go, well, yeah, I smoke marijuana. I said, no, we need about the nicotine: patch, chew, vape, cream, gum. It's bad for HS. Better body weight. For every person who is overweight, obese, I was born on a diet. I think there's a lot of reason, health-wise, to get to your best weight. And it's a very difficult journey in and of itself. These new medicines, the GLP-1 agonists like Ozempic and Mounjaro, these are amazing things happening now. You can talk to your internist about them, because when you have a disease of chronic inflammation, a chronic metabolic disease, you might also have type 2 diabetes. You might have polycystic ovarian syndrome. These are all things that do better with those medicines. Zinc gluconate is a good meal additive, for a meal supplement for patients with HS. It does seem to help. There are cleansers, benzoyl peroxide cleanser and Hibiclens. There's also clindamycin topically. We now are using resorcinol. This is a made medicine. It's compounded. I get it from a pharmacy in Wisconsin, and the information is going to be in one of the slides as we're moving through. This works really well, and it came from Europe. And a lot of patients with what would be called a early stage 2 seem to be able to manage themselves with this ointment pretty well. Laser hair reduction is an anti-inflammatory treatment. There's a particular kind of laser with a particular wavelength and particular settings that seems to be able to reduce the action of inflamed plaque. The lessened hair is a bonus, it's a BOGO, but it's the treatment with that particular set of wavelengths and framework that helps make patients a bit better. There's also something called mediator release testing. This is a set of blood tests that looks at how your body responds to foods with inflammation. So you've got patients who are eating a very healthy diet, but some of the healthy foods they're eating are not healthy for them, and they're stimulating a lot of inflammation. I've had many patients find these foods, and when they eliminate them, they feel better. There's actually a dietitian nutritionist in Michigan who has HS, who is very skilled with interpreting the results of mediator release testing. So let's talk about medical therapy. We've talked about clindamycin topical. Clindamycin is an antibiotic. We use it by mouth. I use it as an additive when I inject intralesional cortisone into people. And we also use it as topical medicine. You rub it on twice a day. It has been effective. It continues to be so. And then there's resorcinol. This is that ointment that we discussed, used in Europe very successfully. There's the information from Smith Pharmacy in Little Chute. You should write that down if you want to talk with your physician about possibly getting it for you. It is very reasonably priced. It's about $50 plus shipping for a 100-gram container, and it's worth trying. Some people don't get as much effect as we would want, but you don't get if you don't try. I tell patients we have 3 buckets of medicine. First bucket is full of things that are labeled for one thing and used for HS, and that includes a ton of antibiotics. And we're not killing bacteria as the primary goal. We're decreasing inflammation. Every medicine has more than one effect. And with clindamycin and rifampin and Bactrim and dapsone and augmentin, these are anti-inflammatory for patients with HS. We use minocycline and colchicine. Colchicine is a medicine that's used to decrease inflammation in gout. I use a lot of doxycycline. We've already talked about augmentin and dapsone. There's a triple antibiotic cocktail that I got from a friend of mine in Paris. Her name is Aude Nassif, and she thinks that there's a huge basis for treating bacterial infections in HS. And there's enough room in the treatment spectrum for all of these things. And if I'm wrong, great, but I'm still making people feel better with these combinations. And that's the ultimate goal. So here we're using 3 antibiotics in combination for 6 weeks. And then we drop the metronidazole for 6 weeks. And then we move to Bactrim, which is a sulfa medicine that is used very often for women with urinary tract infections. This works for a lot of patients. Then there are the other things. There's spironolactone, which is an oral anti-high blood pressure medicine. It's also a mild diuretic. It works really well for women. I don't give it to guys because it blocks male hormone receptor, and it's actually used when men are transitioning to women to block that hormone effect. Birth control, there's one in particular that I use. It's Yaz and its cousins. They are acne protective and low estrogen. I use them a lot. There's metformin. I've not had a whole lot of good effect with metformin. In fact, I've got a lot of patients who come to me in pain, oozing, and you can imagine it. And they're on metformin for type 2 diabetes, but type 2 diabetes is okay, but the HS isn't responding. I use dutasteride in both men and women. Dutasteride is a medicine that men use for prostate enlargement, but we found that it does help in HS. I use a lot of isotretinoin and acitretin. Isotretinoin is Accutane. It is the drug of choice for patients with scalp HS. Acne conglobata, that big coalescing acne on the chest and back and face, is also prime territory for isotretinoin. I use a lot of cyclosporin. Cyclosporin is a medicine that used to be used at high doses for patients to help keep their organ transplants. Dermatologists use it at low doses for HS now, for atopic dermatitis, for psoriasis, and other skin diseases. And it is an amazing medicine and a very low side effect complication profile. MTX stands for methotrexate, and we typically use that because we're trying to keep patients who are on Remicade from making antibodies to the Remicade molecule. It does help in HS, but I've not found it to be that great a medicine for it. So let's now talk about ertapenem, but just give me a moment because I have to let one of my dogs out of the office. Ertapenem is a very effective antibiotic. It's only given IV or intramuscularly. And now my other dog wants to leave. Thank you very much. Sorry about that. This is a bridge to get us truly from one point to another. When I have a patient who is at their wit's end, they're in such pain, they can barely move. This is what I want to get them on. 95% of the patients I put this on feel like $1 million in 3 days. It is best delivered through a PICC line. A PICC line stands for percutaneous intravascular central catheter. And it is placed in the upper arm. It stays there for the duration of the treatment. It is very safe. Sometimes there's a clot or it clogs up and then we have to replace it. It works really well. And I think the IV is the better form to do it. We are now doing it intramuscularly, but whether it's IV or in the muscle, it has to be done every day. And the biggest thing, the thing I'm looking for is in 3 days, they're calling to tell me, man, this is the best thing since sliced bread, but I can't go work out because I got this tube in my arm. And that's okay because I'm using this because they came to see me as a runaway train and I want to bring them back to the station so that we can get them on a more well-tolerated medicine. And when I say well-tolerated, I'm talking about getting it. I can keep them on it from 6 weeks to 3 or 4 months. Now we talk about biologics. Humira is the only medicine that is labeled for HS. And even that labeling, which is supposed to make it easy for us to get it from insurance plans, just means that the insurance companies go through a crap load more effort to keep us from getting people on it. It works really well. I would say that 75% of the people who go on Humira feel like $1 million, and they are good as a single medicine treatment. I always tell patients when I first meet them, hey, you have a disease with a medicines deficiency. And it might be Humira, it might be Humira plus spironolactone or antibiotics as anti-inflammatories. But the minute we fill that deficiency, you're going to feel like a human being again. And the next question is going to be, so how long do I have to take it before I can stop? And I said, well, the minute you don't want to feel like a human being, stop the medicine. You know, you should think about any of these medicines as a new life if it makes you feel human, not as a life sentence. You have a disease that isn't going to go away, that will not leave you alone. And you need to be under control all the time. You know, my threshold for success is very low. If I've got you on something for 2 months, 3 months, and it's not cutting the mustard, we're moving on because I want you to feel like a human being. Every time I have a follow-up, one of my first questions is, are you feeling human today? How many days have you felt human? I want you to feel that 20 out of 30 days as a human being. Remicade is the second one. It's not approved, but it's actually the reason why we have Humira. They're both tumor necrosis factors. They're both going to have biosimilars out. Remicade already has biosimilars. Biosimilar is the code word for generic in a biologic medicine. Humira will have biosimilars out July 1st. I have no idea if they're going to be good. I have no idea if they're going to work the way Humira does because biosimilars, just like generics, don't have to prove that they work. They just have to prove that they are substantially similar to the medicines they are spoofing. Cosentyx should be our next approved medicine. It works really well, but at twice the psoriasis dosing. Taltz, Tremfya, Stelara, these are third-tier medicines. Some people will respond, a lot won't. But again, you won't know unless you try. Now there are JAK inhibitors. JAK stands for Janus kinase. Anything with an ACE ending is an enzyme. And there are a lot of enzymes that are good for you. In fact, all enzymes are good for you. There are some that destroy and some that build. JAK stimulates inflammation. Blocking it makes people feel better. Xeljanz was the original JAK inhibitor. It is used very much in rheumatic diseases, rheumatoid arthritis and psoriatic arthritis. It doesn't work that well for HS, but again, if you don't try it, you won't know. Rinvoq and Cibinqo I've had a lot more luck with in patients feeling good, but they are not single medicines for patients. They're not monotherapy is how we call it. They need to be added to things. So let's talk about procedural options, because when I see my patients, I do it all. I offer all of these medical therapies, and then I offer all the surgical ones as well. When you have a big abscess, that's very clearly an abscess and there's not associated tunneling with it, an incision and drainage will bring you great relief. And we use a punch because if we cut it, the cut is going to seal up and then it's not going to let the stuff come out. And the whole point of opening it is to let it drain. If you've got a whole ant farm's worth of one abscess, most of the time we don't want to cut it because we're just going to give you another opening. But that's a decision made individually. We've talked about steroid injections into the areas. That's why we call it intralesional, into the thing. I use clindamycin because it's anti-inflammatory mixed in with my steroid. HS on roofing is a very reasonable approach to single or dual tunneled plaques. But the minute you've got that ant farm process, it's not helpful. And HS roofing has about a 15 to 20% recurrence rate. And the concept here is that you've got a tunnel lined with a weird kind of skin that creates goop in which bacteria overgrow and you get pus. So we're going to unroof it. We're going to slide a probe through it. We're going to cut along the probe. We're going to snip the sides out and we're going to clean out that goop, but we're not going into fat. We're still within the skin itself. And then we're going to let it heal from the inside out. It's an easy healing process. And it works well for a lot of patients, but you've got to pick the right patient. So superficial radiotherapy is not something that I hear other people using a lot of, but I do use it. Superficial is just that. It's very thin. It doesn't go 6 inches into the body. It won't make your hair fall out. It won't make you nauseous. As it goes a couple of millimeters into the skin, and it's designed to basically remove the goop, scar it down without causing collateral damage. So I'll show you where I use it in a minute. A lot of people ask about Botox. All of the studies that I've reviewed, some of the studies are great, saying, oh, it works wonderfully. Some of the studies say it doesn't. The dosages are all over the place. The bottom line is that there are better ways to help reduce sweating, which definitely figures into inflammation and irritation, than using Botox. And it's expensive. It's not covered. And a bottle of Botox is really expensive. Some people use ND-YAG lasers. That's the laser that we use for laser hair reduction, but they use a different type of ND-YAG, and they treat the areas in an effort to kill hair follicles. I've never seen any utility to this, and it just leaves, I think, very unacceptable scarring. There's something called cryoinsufflation. If you break the word down, cryo is cold. Insufflate is the fancy word for blowing air through something. And you use a special attachment on a bottle of liquid nitrogen, and you blow the cold, very cold, gas through the tunnels, and it's supposed to scar them down. I offer it on occasion when people ask for it. I've never found it to be particularly effective, and it works best when you're dealing with 1 or 2 tunnels, and I think HS on roofing is more effective there. But I'll do anything if I think it's going to help. Here's the superficial radiotherapy. On the left, you can see it's all inflamed. It's oozy. There are multiple points where stuff's coming out. And here he's had it treated. Now, as we get down here, I'm sure you can see this glistening area. This is all pus, but all of these areas are a lot less inflamed. You can do this 2 or 3 times. There are a couple of cycles to it. Have a radiation oncologist who helps me with this because I don't have this procedure in my office. But I want to have something for everyone. I do not want to, I never want to say to someone, I can't do anything for you. I will always try. So let's talk about the burden of HS. You have these ant farms in your underarms, your groin, on your breasts, scalp. They're like ticking time bombs that will explode at random times and then reset themselves and do it again at random times. You've got mounted plaques of scar. We've already beaten to death the fact that they hurt and they ooze and they smell. I need to reduce those. I need to make you less painful. I want to reach in and just take that thing out. So that is the goal for what I do with the CO2 marsupialization. Here, you can see a right underarm, and you can see multiple tunnels. And when you palpate it, it's very thick. It extends up underneath the hair. Here's a really involved thing. You can see multiple openings. You press here, and pus comes out here, pus comes out here, pus comes out here. It's whack-a-mole, and you don't have enough hammers. Here you've got it in the groin. And with the stage CO2 marsupialization, what I can do is I can reach in and take out this huge area, and I do much bigger areas than this. And you can see where my line for numbing was. We did this in the office. We do it under tumescent anesthesia. It's the same anesthesia that we use when we do liposuction in the office. Awake, comfortable, not in pain. And you can see how wide it is, but it is very thin because remember, this is a disease of the skin. I don't need to take a gigantic chunk out of you and then try to sew it up in a straight line with stitches or staples or put a meshed skin graft or even move tissue and muscle to cover the area. You don't do that. Here, you can see picture number 3. Just move my thing out of the way. There we go. This is about 2.5 months of healing, and here we are completely healed. It's an incredibly, reasonably good-looking scar. You're exchanging this for that. The recurrence rate here is 5%. I have a 95% local site recurrence rate. Local site cure rate. I misspoke, my apologies. Here's a guy who came to see me from a colorectal surgeon. They said that if they were going to take all of this away, and he has continuing up onto the buttock, they were going to have to do what's called a diverting colostomy, where they disconnect the anus from the colon and put it out onto the belly and put a bag there. And then they were going to have to remove all of the skin and all this tissue. Was there something I could do? And you can see it's a huge plaque, and it goes up onto the scrotum. There's a huge piece right here. And this is what I took away. Up onto the scrotum, there's 2 parts of the scrotal sac, the outer part and the inner part. And I didn't penetrate the inner part. I took all of that disease away. Here's about 2 months. This is at 5 months. It's completely healed. This did not cause him any problems. It didn't lose range of motion. It's a very reasonable and functional healing process because you're using Vaseline, nonstick pads, gauze, and tape. In fact, you get more irritation on the normal skin than you do in the areas that we worked on surgically. Here's his backside. These are called setons. These are rubber pieces of rubber that are passed through fistulas, connection from point to point, and then they tighten them. They're designed to keep it open so that it doesn't get infected. And they tighten it and they tighten it, tighten until it pops through the skin and you've gotten rid of the fistula. But this is not a pilonidal sinus. So I went and I removed it. This is the top of his tush. Here it's 2 months in healed, and here it is completely healed. So there's always something that we can do for HS. I never tell patients there isn't anything to do, and I will continue to try as long as you continue to try. HS Place is for medical professionals, nurse practitioners, PAs, doctors, researchers, where we discuss difficult cases with HS, where we discuss the new findings, where we talk about everything that we need to talk about to help patients. HS Foundation, again, physicians dedicated to making HS the least annoying that we can. And supergroups like the one we're talking under the auspices of tonight, Hope for HS, HS Connect. Every support group that you can name is valuable because it means you're not alone. So that is my talk. I'm always learning and I'm always teaching, and I appreciate your time.
Thank you so much, Dr. Resnik, for your amazing presentation. I know I learned a lot. Thank you for that overview of HS, and also busting some myths for us. I really hope that you all got a lot out of this conversation today or this presentation today. I want to get into the Q&A. And if those of you, we have lots of questions, but if you all have any questions for Dr. Resnik, there is a Q&A function at the bottom of your screen, should be at the panel, and you can submit your questions. We're going to try to get to every single question, but we only have 30 minutes allotted for this section. So I just want us to all keep that in mind. So if we don't get to your questions, we do apologize. And it's not anything personal. We just want to make sure that we respect Dr. Resnik's time, your time, and our time as well. Okay. So the first question that we have is about genetics. So can you tell us what role genetics plays in hidradenitis suppurativa?
We don't know yet. There are a lot of studies going on, and as part of my intake, I do ask patients, do they have first-degree relatives? Do they have any relatives with HS? And once I get a yes for that, I'm pulling them out and I'm talking about that with my genetics colleagues, but we don't have an answer for that yet.
Can you go over the stages of hidradenitis suppurativa? And also, I think a good thing to classify is, I personally have heard that we are moving away from using the Hurley stage system. Is that true? And if so, what is the system of classifying HS now, or the levels of HS, the severity?
I don't know who we is. The Hurley staging was made by a guy named Hurley in the late 80s, and he's a general surgeon, trying to understand who gets surgery, who doesn't. It is a staging that really doesn't have any utility. It doesn't tell us where you're going. It only tells us where you've been. And the only reason we even use it is because we need Hurley stage 2 to force an insurance plan to pay for Humira. So there isn't a staging. I don't think about staging. When you walk into my office, no matter how minimally involved you are, no matter how horrible it is for you, you are your own arbiter of how severe you are, and that's how I treat you. So I don't need staging. I don't use any of the rating systems. You tell me you're severe, that's where I'm going.
Can HS cause cancer? I think that's a good question.
Long-standing, scarred, inflamed plaques, and when I'm talking long-standing, I'm talking 20, 30 years, have a very small possibility of having what's called a Marjolins ulcer, which is a squamous cell carcinoma that develops because of all that inflammation. It's also seen in late stage burns, but HS does not cause cancer in and of itself.
What is the specific laser treatment that you mentioned that helps with HS? I think they're referring to CO2 laser.
Every laser puts out a wavelength of light that is absorbed by something in the skin. The ND-YAG laser, either long pulsed or Q switched, and trust me, it doesn't matter understanding that, but there are two different kinds of ND-YAG lasers, are designed for pigment or pigment at the bases of hair follicles. So The long pulse is the one that's used for hair removal and helps to make it harder for HS to take control in skin, and it makes it easier to decrease the inflammation. The Q-switched Nd:YAG is that one that's designed to try to destroy the hair follicles by giving them so much energy that they vaporize. But there's a lot of collateral damage with that. So I can't tell patients what to do. You need to talk with the physician who's working with you. I would tell you laser hair reduction is a much smarter way to go from my perspective. That's what I offer. As far as staged CO2 marsupialization, the CO2 laser puts out light that is absorbed by water. I use it to cut and dissect that ant farm off of the fat, just taking what I need to take. It's a disease of the skin. I'm taking the skin. No matter how thick it might be on the top, it's always fat underneath. So if you got this horrible plaque of mess that hurts you all the time, the minute I take it away, you might have a little pain from the surgery, but that constant 24/7, 365 ooze is gone. So that's the laser that I use for that procedure.
Dr. Resnik, have you ever done CO2 surgery on someone who has Hurley stage 3 or severe HS? And how extensive would that surgery be?
I do it on Hurley stage 3 all the time. The more involved the skin is, the more I can help. And really, there isn't any other way to make it go away. You know, if you're on a medicine that keeps you under control, that's great. But the scars are yours to keep. And we want to get rid of that. I think that the scarred plaques, the scars that we get from the surgery are so much better because they don't hurt, because they don't ooze, they don't sting. It's not that ticking time bomb. So I don't have a hard stop for pretty much anything. And that's a good general way to think about it. There are areas where I cannot go because of involvement with other more vital structures, but I haven't met a patient who I could not help.
Since we're talking about surgeries, I want to ask you a question regarding insurance. When do you think insurance will see that this condition is debilitating and cover the cost of surgeries?
We've been trying to get it covered for 6 years. There's ongoing efforts. It just has not happened.
This is a question that I have that I think that pertains to this. Is there a code that is specific to HS that physicians can enter in to help patients get qualified for HS surgery with some insurance agencies?
Not for this procedure. There is no code for this.
Is HS progressive? Will it just continue to get worse over time? Are there any factors that play a part in it getting worse over time?
If you don't control it, it's going to get worse. You know, there's a saying in life, hope for peace, prepare for war. In HS, it's hope for no flare, but get a flare. But when you're on medicine that controls your disease, if you're going to get a flare, it's going to be a lot smaller. It's going to go away more quickly. It's going to leave less destruction. It's going to heal better. If you don't have control, the disease will progress. And there's no way for me to tell person to person how far it's going to go. It's just going to get worse. Because think about it. You've had it for 3 years or 5 years or 7 years or 2 months. Continued explosion and healing destroys and evolves more and more tissue. It's a cascade, and it's never going to leave you alone.
When it comes to HS in the buttock area, if someone is experiencing high amounts of drainage, what would be a way to help combat that or to slow that down?
Bottom line is control medicine that controls your disease. You know, if you talk about wound care, there are absorptive dressings, but that sort of skirts the issue. We want medicine that's going to stop you from leaking. That means it's going to decrease your inflammation. So what's that going to be? Is it going to be Humira? Maybe. Is it going to be Remicade? Okay. If we're fighting with an insurance plan to get you on this stuff, it's probably easier to get you on ertapenem which, as I pointed out, 95% of the time stops you oozing immediately within 3 days and keeps you going for as long as you're on it. So there is no easy answer for that, because take it from your buttock, put it in your underarm, put it between your breasts, put it on your scalp. You lay down and your scalp sticks to your pillow. You never know what you're going to leave when you get up off of someone's couch or in someone's car. Control is key. And your physician shouldn't stop until he or she helps you get control.
How is mental health related to hidradenitis suppurativa?
HS makes you depressed. It makes you anxious. It is a brutal disease on all fronts, mental and physical. And a lot of patients don't recognize it. They're in a lot of pain. They can't really move. But part of that is being depressed. Your sleep is off. You don't eat well. Sometimes you binge eat. Sometimes you eat chocolate because you're looking for some release. I talk about mental health with patients. When they say to me, I'm depressed. I tried to commit suicide. We need control for that reason too, because when you get control, even if it's for a week and a half from a shot of cortisone in the butt, you're going to see that there can be light at the end of that tunnel. And that helps you. If you're clinically depressed, you need more than my control. You need help. You need counseling. You need medicine. It's hard to ask for that help. And on our first visit, I'm not going to beat you over the head with it. I'm not going to say, hey, you need a psych evaluation, because you're never going to come talk to me again. But I think most people have insight into that, whether they want to do anything about it, whether they feel they can do something about it. They know that they've got it. So talk to your clergy, talk to your rabbi, talk to your priest, a pastor, talk to a mentor, talk. Keeping it inside doesn't help.
Do you recommend a food sensitivity test for monitoring what may trigger HS flares?
The food sensitivity testing that I recommend is that stuff called mediator release testing. This is not a disease of allergy. So getting food allergy testing doesn't make a whole lot of sense. Finding out what stimulates your body with inflammation does. That's the one I'd recommend.
I know we discussed this a bit already in the beginning, but is HS a follicular disease, or is it a condition that has to deal with the sweat glands?
It is not glands. It's not sweat glands. It is follicular occlusion. That's the fancy word for plugs in your pores. And sometimes you can see them, sometimes you can't, because blackheads in the groin, under the arms, in areas of HS are very common. In fact, they're called tombstone blackheads or tombstone comedones, where you've got a little bridge of skin over them. And they are the start process. And you can have a lot of disease there, and you can have these blackheads. And a lot of people don't like the look of them, and they want to feel better. I take the blackheads out. It's easy. And we also deal with the darker skin and the scarring that comes along with it. Again, once we've got control. But everybody wants to look their best. And if they have a problem, if they have an area that bothers them, I want to do the best I can to improve it. I can't snap my fingers and make it all better. But darn it, I'll try.
Does menopause decrease the activity of HS in women?
I would say that most of us who treat HS on a regular basis don't have that many more mature people, like 60. Oh my God, I am so old. But I don't think that menopause makes as much change as we would hope, nor does andropause do it, because I got a lot of guys who have really terrible HS and it continues to plague them. So, no.
What role do hormones play in flares with hidradenitis suppurativa?
Not much at all. We use spironolactone to help patients because we know it blocks male hormone receptor, but when we run tests, people don't have elevated hormone levels. In fact, one would presume that guys who are doing testosterone therapy for low T would have worsening HS, and it's not that way. So this is not a hormonal disease the way a lot of people think about it. Oh, my hormones are out of whack. I whack them back and poof, it's better. Doesn't work that way. But again, we are at the rebirth, the renaissance of HS. And every day there's more and more research being done. And every paper that adds to that body of knowledge points us in a better direction.
So, what about patients who are experiencing flare-ups around periods and women who also have PCOS and HS? In those cases, there have been some research that have pointed to hormones affecting women in their HS flares. Would you say that that is correct information, or do you have a different perspective to offer?
There's no different perspective. Women note flares around their periods. So that's what I'm saying. We don't know enough to say, absolutely not, it's not a hormonal disease. I am telling you right now that for women with HS for whom I do bioidentical hormone optimization, if I give them more estrogen, their disease doesn't get worse. And I use testosterone in women as well, and their diseases don't get worse. So when I say it's not a hormonal disease, the first thing people say is, oh, well, it gets worse around my period. Why? Isn't it hormones? I don't know. The bottom line, though, is that the more control we have, the less likely that is to happen. So we're all casting about for answers, and the more work we do, the more we'll have.
Can the side effects of medication create more damage to the body than hidradenitis suppurativa?
It's always possible. Death is a horrible side effect, but I've never had anyone have a problem with the medicines. I tell patients that, practically speaking, these don't have any side effects. And aside from something like Stevens-Johnson syndrome, which is a very terrible allergic reaction to a medicine, there aren't many things worse than what people go through on a daily basis with their HS. So when patients come into me and they say, I'm at my wit's end, it's like a bad country song. My wife left me, my husband left me, I ran over my dog, no one loves me. I can't take it anymore, doctor. And I say, well, you've never tried Humira. It's a great medicine. I think it'll make your life so much better. So they've already said to me, they can't make it anymore, which says to me suicide. Then I offer them the medicine, and then they say, well, what are the side effects? Anything is possible. Practically speaking, there aren't any. So I want to help patients. Sometimes you can't.
How do you typically apply clindamycin to the skin?
Insurance is a pain in the tush. Insurance won't pay for the gel, which I think is easier to use. They'll pay for the solution, but both the gel and the solution have an alcohol base and can sting on open skin. So if you put it in the fridge, it'll sting a bit less, and you just apply it. I think the resorcinol works better and is better tolerated because it doesn't sting so much. But that's how you do it. You just rub it in.
Can taking vitamin B12 improve or affect HS in any type of way?
Not that I'm aware of. Having enough B vitamin is good for people, but I'm not a big proponent of tons of vitamins. I think they just produce very expensive urine. A lot of people swear by B12, it gives them more energy. Okay, whatever makes you happy, whatever makes you feel better. And if B12 makes you better, great. I'll use it in other people and we'll see if it helps. Because as I tell patients all the time, there's something that will help some of the people some of the time. And I am all for trying whatever it is.
How do you know what stage of HS that you have? How do you know how severe it is? Is there any indicators?
You can look up the definitions and apply them to yourself. I would tell patients, don't look on yourself as a stage. It doesn't really matter. Right now, you are your worst HS self, and we need to make you better from that point. Because staging, like I said before, Doesn't do anything except help us force an insurance plan to pay for an expensive medicine. Doesn't do anything else except drive people nuts and make them depressed.
Are there medications that will help HS and are also safe while to use while breastfeeding?
Yeah, most stuff doesn't pass through breast milk, and when it does pass through it, it's not going to get through the baby's gut. Perhaps you also want to expand that to pregnancy. We're looking at the medicines, particularly the biologics, and see how they work in pregnancy. And our assessment is that all the stuff we're using isn't going to cause any greater harm than you might see in patients who aren't taking any of these medicines, in a patient who is pregnant and not on any of these medicines. Cimzia is the only one that doesn't pass through the umbilical cord to the baby. So it gives a modicum of betterness for the baby, because when we're using Humira or Remicade, we caution mom and pediatrician, dad too, not to give any live vaccines to the baby for the first 6 months, so that all of that stuff passes out of metabolism. But Humira, Cosentyx, Stelara, Tremfya, Remicade, they're all deemed to be safe during pregnancy. And if the patient is severe enough and the disease would be so explosive if you're not under control, is deemed okay to use. And of course, that's going to be the ultimate decision of mom and husband.
This is going to be a very morbid question, but very necessary. Can you die from having HS?
You just live in hell forever without control. And I know I keep pointing that out, but HS isn't going to kill you.
Do you have any thoughts on turmeric and zinc and how they may help to reduce flares, if at all?
I recommend zinc gluconate as a dietary supplement. Turmeric is great. It's spice in Indian foods. It causes a lot of people's stomach upset, and it helps a lot of people. And they also have it in creams and lotions and soaps. And again, if it works for you, great. Try it, use it, do it.
What are your opinions about HS possibly being a blood and lymphatic disorder, causing the body to not be able to pass toxic waste, and therefore it's transferring through the skin? I believe is what the question
There's
is.
nothing, there's nothing that says that that is the situation of the case. It's not bloodborne. It isn't toxic buildup. Patients purge and do detoxification on a regular basis in high colonics and drinking apple cider vinegar and all sorts of unusual stuff. And the bottom line is, if it makes them feel better or works for them, then I'm all for that. But there isn't any basis for it. I am not hanging my hat on studies. I'm hanging my hat on stuff that I have found that helps patients with HS. I will use anything that I come across that seems to work. Something's reported for 4 patients, I'll try it. Those thoughts I find difficult because I need a kernel of truth there. I need something to go with. There isn't any bloodborne stuff. There isn't any toxin that's causing this to happen that I am aware of.
Is there any possibility that we are near finding a cure for HS?
Might happen tomorrow, probably won't. But there is so much more research going on in the last 4 years than there was in the last 15. So the chances of significant breakthroughs are getting better every day.
Is it possible to get HS in other areas of the body, like the legs and the ankle?
Yes, most of the time what you see on legs, abdomen, is something called pyoderma gangrenosum, another skin disease that is often seen along with HS. And ultimately, again, it doesn't matter what happens as long as we can control it. And that stuff happens sometimes in spite of control. That's why you can't be complacent with what's going on. You have to be aware of what's going on in your body and help your doctor, help yourself.
The next question we are going to ask is Crohn's disease and HS related in any way?
It has been seen together. When we're dealing with plaques in the groin and around the anus, we're always thinking of something called um, cutaneous Crohn's, where you've got a piece of Crohn's disease, but it's not where it's supposed to be. It's rare, but we see it often.
The last question that I'm going to ask is pertaining to antibiotics. I think this is a good question. Is there any worry about overusing antibiotics and patients becoming resistant to them? And what is the solution for that?
No, it's always a risk benefit analysis. If I can use an antibiotic anti-inflammatory and keep you under control now, I'm not worried about whether you're going to develop a tolerance to that particular antibiotic. There are enough antibiotics right now to cover all of the different infections we encounter. And if we find that you get a particular infection that requires antibiotic therapy, we'll find an antibiotic to deal with that. So I'm not worried about that.
So thank you so much, Dr. Resnik, for sticking around for the Q&A. Thank you so much for your time, your talent, and your energy. Thank you, thank you, thank you.
It's my pleasure. Good health to everybody. Have a good night.
You too.